Hello everyone, welcome to the very first session of the CUIE Webinar series. I'm Jaitem Suwanwela, and I'm so glad you're tuning in with us today. We are currently witnessing the era of integrated digital dentistry. Digital dentistry has evolved far beyond simple scanning. It is now the backbone of modern treatment. In the Chulalongkorn University Implant and Aesthetic program, we are proud to be a leader in this evolution. We emphasize that true success comes from mastering this digital ecosystem.
Rather than mastering individual techniques or protocols, the modern challenge we face today is to create a seamless workflow from a long list of devices and technologies. I'm Nikos Mateos at CUIE, looking forward to this webinar.
If you practice implant dentistry, you know the pressure. The patient sits in your chair with a failing tooth, and they ask the big question, can I get an implant and a tooth today? Immediate implant is the ultimate service for our patients, but it's also the ultimate stress test for the dentist. If you do one thing off, then you might risk aesthetic failures and biological complications.
Today the challenge is to actually combine the timeless biological principles with our understanding of the technologies and how they can interact with our patient for the best outcomes. Modern immediacy is not about just placing implants in the extraction socket. It's actually a complete workflow, starting already at the digital treatment plan and then continue to detailed prepare prosthetic components and the surgery, aiming to deliver function and aesthetics with one clinical contact point. It might have a lot of steps and a lot of procedures that we have to pre-plan, but if we get it right, we can deliver unprecedented outcomes for the benefit of our patient.
We have a packed session and a live Q&A after this. So get your questions ready. We are eager to change the way you look at the immediate implant treatment.
So let's get going and see you right after the seminar. So, as we discussed, it's not about learning a new device, a new tool, a new technology, or a new protocol. It's about a new mindset. It's what we call a paradigm shift. That means that we orchestrate a whole new workflow using the timeless biological principles and understanding, and also different devices and tools in a sequence that now empowers us to do unprecedented clinical outcomes. And by paradigm shift, we mean also the change in our viewpoint. We see implant dentistry, implant therapy as something different, and we can achieve outcomes that we could never get before. So how is this workflow organized? Of course, we start with collecting essential data. And this time is not just the clinical examination or the patient's history, but now we're collecting powerful three-dimensional clinical imaging. That can be radiographic from the cone beam CT or from the intraoral scanner or even a facial scanner, which now can help us into a CAD software to reconstruct the exact three-dimensional anatomy of the patient with all its characteristics, its personal features that we have to take in consideration. And this is exactly where the treatment plan happens. On the virtual space, our digital treatment plan now can start and visualize the entire treatment before we even catch the blade and cut in the surgery. Essentially, we start from the visible part, which is the tooth. This is the not negotiable part because the anatomy of a tooth is directed by nature, by aesthetics, by function. And once we place the virtual teeth in the optimal position and shape, then we can from this derive the supracrestal complex, this essential fundamental space where tissue and components and bacteria meet, which extends from the mucosal margin all the way to the platform of the implant. And when we design this based on the evidence and the understanding we have, then the position of the implant comes as a natural extension. the place, the type, the kind of the implant will complete the big picture. And now this digital treatment plan becomes the baseline, the start, but also the end point of our treatment. We do plan only once, rather than fragmented different areas where we plan the surgery and then we plan the prosthodontics. Now we plan one system for the rest of the treatment. And this digital implant treatment plan becomes a product in itself, becomes something that we can store, that we can exchange, we can share, we can work collaboratively. We can even share with different technicians, clinicians, and the patient. And remember me, the digital treatment plan, who owns it, will be one major battlefield in the near future. But that is something to discuss in a different opportunity. Now, once we have finalized the treatment plan, this can now be exported and can be shared. But what is very important to note here is that we only have one chance to get it right. Once you get it right, then the procedures will be automated and follow up. If you have, however, problems, errors, mistakes, deficiencies in your treatment plan, no matter how good the surgeon or the prosthodontics, this will compromise your clinical outcomes in the shorter or long term. So we realize now that not only we have the tools to design with precision, but also we need to supplement these tools with the basic biological evidence-based understanding of how to design for long-term success, because design matters and we can get it right only at the very start. Now, this will be also a preventive aspect of our treatment plan, because we know with all the precision that we have and with the understanding that we have, we can design restorations that can be preventing problems in the future, or if we don't follow the principles, we can design restorations that predispose to trouble, like for example periimplantitis and periimplant tissue inflammation. And all this is essential knowledge today that strengthens our ability to carry out successful treatments in the long term. Now, once the digital treatment plan is finalized, we can export it in different directions. One direction is the prosthodontic components, where we can prepare, we can prefabricate with milling or 3D printing the components of the prosthesis and have it ready at the time of the surgery. And of course, the second direction is to export for the surgery itself. And this now supplements the personalization, because it's not only the prosthodontics that is personalized, it's even more the surgery. The implant placement now has to fall exactly in the position directed by the digital treatment plan. And guided surgery has different options. We can place this with a surgical guide. We can do this with the dynamic real-time navigation, or in a few places we can now also do this with a robotic placement, task autonomous or collaborative robots. And these two together, personalized prosthodontics and personalized surgery, fulfills the complete individualization of the workflow. Now we can do everything for the exact individual patient with very, very little space for deviation and error. Once now the surgery is conducted and the implant is restored, we have established a virtual baseline. We have a virtual twin of our implant treatment, which is stored and can stay as a benchmark, as a reference for every future examination. So whether we examine the patient again in the future, or maybe in the near future the patient examines himself with self-monitoring tools, we can always revert back to the original and we can quickly and easier trace changes. Any modification on the technical or the biological part that might alert you to some underlying problem. So this is now increasing the participation of the patient as well, bringing up another P, the participatory approach. Now, when we try to apply all this in the aesthetic zone with guided immediacy, then we have really a lot of biological underlying factors. We have many tools, hardware and devices, but also much software, which sometimes is not aligned perfectly to each other. So here we will have to see the whole operation as a workflow. And I would like in this small webinar today to focus on two different points. The first one, as we said, design matters and why it matters. And the second, how the customization, the individual approach of the surgical procedure with dynamic navigation can help us, or where could there be potential for glitches and errors sneaking into there as well. And starting with design matters, who better to explain this to you than Dr. Jaijam?
Thank you, Dr. DeCoste. We often talk about guided surgery as a surgical tool, but in digital workflow, the surgery is actually the final step of the restorative plan. Before you even touch a drill, you are using your planning software to design the ideal tooth first, calculating exactly where that contour and emergent profile need to be. With this approach, guided surgery isn't just about where the implant can go, it's about exactly where the prosthesis needs it to be. By the time we reach the dental chair, we have already engineered the provisional to act as a scaffold, supporting the soft tissue from the moment of placement. That's what takes us from a successful surgical procedure to a final restoration that perfectly mimics natural biology. But why this is so challenging in practice? It's because the emergent profile is where nature meets our engineering. As soon as that tooth comes out, we are fighting against changing socket contours and biology that wants it to collapse. We are also trying to bridge a significant anatomical gap, trying to make it small, round implant mimic the wide, irregular shape of the natural root. If we don't proactively support the soft tissue and the papilla right now, we are going to end up with those black triangles. The goal of our digital planning is to take the guesswork out of this. It allows us to solve these biological challenges on a screen before they even ever become a reality in the chair. So that leads us to the million-dollar question. How do we actually create a provisional that delivers on those aesthetic goals? We have to stop thinking of provisional as just a temporary tooth and start seeing it as a custom molding tool. Since we have already identified the risk of soft tissue collapse and black triangle, we need to use our digital design to engineer a scaffold that literally tells the soft tissue where it should stay. It's about being proactive with the biology rather than reactive. So let's look at the specific design parameter we use in the software to make this happen. To turn our provisional into that molding tool I just mentioned, I will focus on two specific design variables. The first one is the angle and contour of our provisional restoration. And the second one is we will look at the emergent profile through the lens of convexity and concavity. To ensure our design is biologically sound, we have to look at the evidence. So in the study, the very first one, they used 2D radiograph, which is a periapical radiograph, to see the link between the shape of the restoration and the inflammation. This study, they measure what we call total contour angle, which is the part from implant platform to the gingival margin. And the data was clear that once you exceed 30-degree angle, you are in the risk zone of pre-implantitis. So that's mean when we over-contour or create too much convexity near the bone, we aren't just shaping the soft tissue, but we are actually invite the marginal bone loss and future recession. This is why our digital design is so important, because it lets us know where the contour should be, so that we do not over-contour and press the bone, which cause the bone loss in the future. Moving beyond those early 2D study, the later generation of research used 3D analysis, which came from CBCT data. This gives us a much more information of how the prosthesis interact with the soft tissue. Specifically, the studies highlight two important zones. The first is the mucosal emergent angle, or MEA, which measure right where the tooth breaks through the gum. The data from the research shows that once this angle exceeds 40 to 45 degrees, you have higher risk of inflammation. Then we have the deep angle close to the implant platform. If this angle is too steep, it's directly associated with the early marginal bone loss. So we have to make sure that this area is straight, not too steep. Now, more than the angle is the emergent profile. We have to look closely at the actual geometry of the emergent profile. The basic concept by Zhu and colleagues divides this into critical and subcritical contours. That the first millimeters around the gingival margin is what we call critical contour. And this area has to be convex to support the final tooth shape. However, the zone lower than this, which is a subcritical zone, it has to be concave. And this is what creates a volume and space for thick soft tissue. We can define this even further by using the aesthetic biological contour concept. This breaks the profile into three specific zones. The first one is the aesthetic zone, or E zone, which is the top part of the gingival margin. Pretty much the same as the critical contour, it has to be convex to support the sulcus. The next zone is the bounded zone, or B zone. It has to be concave. This is where the junctional epithelium is. And the last one, the crestal zone, which is the C zone. This is the area near the bone, and this area has to be straight. If we over-contour this crestal zone, we'll risk the marginal bone loss we discussed earlier. In our digital workflow, we are essentially designing the biology by ensuring these three zones are correct before the surgery even begins. Now that we have mastered the design of the provisional, the next big question is the timing. Immediate provisionalization is our gold standard for aesthetic zone because it provides that critical soft tissue support from day one. However, it has a high risk because you must have excellent primary stability and you have to have a strict occlusal control. On the other hand, if you're going for a delay approach, it is safer biologically in terms of integration. However, we have a higher risk of soft tissue collapse and making the aesthetic goal that we try to reach harder. So how do we bring that digital plan to life in a chair? The technique that we use can be what we call direct fabrication technique. So we start with the 3D printed or mill-tail provisional crown with ladder wing that the wings will hold onto the adjacent teeth. It will act like a seating guide on adjacent teeth to make sure that our position is perfect when we put in the mouth. So we put this 3D printed shell in the mouth with the temporary abutment, and then we pick up this shell onto the temporary abutment by using composite resin or the acrylic. We take it out of the mouth to trim those wings and also refine the emergent profile extraorally. So this is where we add the resin to finalize that subcritical and critical contour we designed. And then we have to create a smooth surface before the final delivery. So the good thing about this technique is it's fast, it's a predictable way to translate our digital geometry to our temporary crown, which is a molding tool that we have here. One of the most important critical steps in this modification of the temporary abutment is many stock abutments have a built-in flare or widening of the base. So we have to trim this area because if we don't, that metal can actually contact the crestal bone, which will prevent the restoration from seating fully or trigger bone loss after. Now, if you don't have digital tool ready to go, you can always go back to the more conventional way, which is the indirect fabrication technique by using conventional technique. So how do we do it? While we are in surgery, we capture that implant position by using open tray impression coping and lute the acrylic or GT pattern resin between this implant impression coping to the adjacent teeth again. It will be on the incisor edge or occlusal surface of the adjacent teeth. This creates our intraoperative index. This is just to make sure that we have implant position as in the mouth. And then we go back to the lab. What we have to do is we have to make some room in a stone cast so the analog that we just made and connect to the surgical jig that we have with the open tray impression coping and a jig, make sure that it can be fit back to the model. Once we seat the index into the model, we just fill that space with fresh stone to lock the analog into the perfect orientation. So this is the advantage of this technique is it's reliable, hands-on way to make sure in the lab model is perfectly match what we have in the chair. And then when you have this implant analog in position in a cast, you make sure that now you have the position of the implant the same as you have in the patient's mouth. Once we have the analog ready in a model, it's time that we are going to build the final shape. So what we do is we will apply our resin between the abutment and the shell and filling the space and make sure there's no void and the surface around the immersion profile is smooth. And again, we have to make sure that this subcritical zone is not over contour. We want to make it slim so then we do not over compress the bone, and also we want to have a space for soft tissue. The benefit of doing this technique is the ability to sculpt and polish the restoration extraorally, less chair time, however you will have more time in the lab. And the major disadvantage of this technique is once we trim away or we have to make a hole in the stone model, we remove the gingival portion in the stone model. So we lose the sight of the actual gingival margin. This means we are essentially blind the exact soft tissue level, which makes it much harder to replicate those critical and subcritical contour we try to design. So right now we are lucky that we have all the digital tools that we can use. So how does it look in a fully digital workflow? This is where everything we have discussed come together. We start by merging our CBCT for bone planning with an STL scan of the tooth before it's even extracted. By doing this, we can use the original tooth as our ultimate blueprint mimicking its natural contour to design the temporary crown. And this allowed us to kind of pre-calculate and engineer that ideal emergent profile directly in the software. So once that provisional that we made is in the mouth, there are 3 very important jobs for this provisional to do. First, as we have seen, the emergent profile must be contoured specifically to give the soft tissue room to thicken. Secondly, this provisional restoration is a biological seal. It needs to close off the entire socket to protect our graft material and keep it from moving or washing out during those first critical days after we have immediate implant placement. And third, and this is the detail you can't skip, is you have to make sure that your provisional is highly polished and free of porosity, because we want to minimize plaque accumulation during this healing time. We also must ensure that the provisional remains entirely clear out of the bony socket. Nothing is pressing down the socket to prevent any pressure on alveolar housing or our grafting material. Restoration must be non-functional, absolute out of occlusal contact in both centric and eccentric excursion. And we must also maintain a passive proximal context to prevent the force transmission from the natural mobility of the adjacent teeth as well. Finally, I recommend this provisional restoration to be a screw retain design to provide retrievability and, most importantly, to eliminate the biological risk of gingival cement remnants during this healing time.
Computer-assisted implant surgery is an overriding principle that has matured a lot in the last decade. A little bit more than a year ago, we gathered here in Bangkok at Chulalongkorn University with a dream team of international experts to discuss exactly this. How far have we come with guided implant surgery, computer-assisted implant surgery, and what is it that lies ahead? And it was 2 very fruitful days that have produced a lot of outcomes. You're very welcome to read these papers. They're available right now, open access through our ITI white papers. But if I was to sum up a little bit the major focus and the major agreement we had on that day was in one picture, that essentially we're moving into a new paradigm where design is in the center of implant dentistry. Computer-assisted implant surgery is not really about surgery. In reality, it's something much wider, and it's a workflow which starts with one essential prerequisite, and this is the digital implant treatment plan. There is no point to place an implant accurately if you don't have a very well-conducted evidence-based treatment plan. Accuracy has only meaning and makes only sense as part of a very precise design and workflow. Therefore, we see today as this digital implant treatment plan as the standard of care, because it gives you the tools, it gives you the potential and the possibility not only to unlock immediacy or immediate loading, but also primarily to design for long-term success, to use all the evidence exactly where it matters and make sure that your implant treatment is actually fine-tuned for the best potential for the individual patient. Now, once we have the digital treatment plan, then we can go ahead and prepare all the components and place the implant. And the implant you can still place in many different ways. You can still place an implant without guidance, non-guided. And that might still serve the purpose when you have straightforward cases, cases of low complexity, or when you follow a conventional workflow with longer period intervals and with impression and controls in between. However, if you're moving to more complex workflows and if you're moving towards immediacy, flapless placement, immediate loading, then you will benefit greatly from using the guided placement, which minimizes any potential for error or deviation from your original plan. And that you can do in three ways. You can use the static approach, which is with the surgical guide. You can use the dynamic approach, which is a totally different technology with real-time navigation, or if you have available, you can use a more futuristic approach with a robotic placement. And these three become more and more important as our workflow is becoming integrated, unified, and seamless. Now, looking at these three technologies, the static is the established approach. It is available everywhere where implants can be placed. It is well documented. It delivers high accuracy with certain known limitations. The dynamic navigation is a rising technology. It's something that has increased its application in the last few years. It's a technology with a lot of research, with very good documentation, but also with potential to expand and increase in the very near future. So this would be for me the technology that right now is worth investing into. And then, of course, comes the futuristic approach, the robotic arms, which either as task autonomous or as collaborative can help the surgeon or replace certain aspects of the surgery on behalf of the surgeon and achieve levels of accuracy that have been unprecedented in previous technologies. Now, we will focus a little bit more today on the navigation. This is the technology that we use increasingly in our immediacy cases, and this technology is based on a very specific system of spatial positioning. That means that we have a system that helps us position in the patient's anatomy and give real feedback of all the instruments that we use in the surgery. The main navigation systems are based on optical tracking technology. That is a system where through stereoscopic cameras it can continuously monitor the surgical field and give real-time feedback to the surgeon about the position of his instruments, just like operating with the GPS. And these two stereoscopic cameras, sometimes more, sometimes less, sometimes supplemented with different devices like infrared, for example, cameras and omitting devices. This can have many configurations, and depending on your generation, we have given different names to these cameras in our clinic. Now, the optical tracking technology is something relatively simple in principle. We have the patient placed in front or below these two cameras, which continuously monitor the surgical field. But these two cameras, they cannot see the patient. They can actually see nothing other than the trackers, the QR code-like structures, which are firmly attached in the jaw that we operate and on the handpiece that we're holding. And then by triangulating these trackers, they can in real time give the position of the drills or of the instruments projected on the patient's anatomy as in the cone beam CT, and how they relate to the optimal implant position of our plan. So the surgeon can use this information to conduct the surgery still freehand, still directly looking at the surgical field and having full control of the operation and the procedure, but with the additional value of a visual aid that can give him with precision below of a millimeter his position of the instruments and how they relate to the ideal implant placement. Of course, these trackers are essential, and these trackers, of course, are not invented for implant dentistry. Actually, optical tracking technology has many applications overall in technology. One of the most enjoyable for me has been the optical tracking applications in a virtual reality gaming show that we have nearby in Bangkok, where you can take up a VR gun and a VR set and wear these trackers on your back. Then the system throws against you a virtual environment where you can fully interact and usually be attacked by all kinds of monsters that you will have to shoot against. Now, All this, of course, is possible because of the computer of the navigation system, which creates a virtual space, a virtual three-dimensional space where everything refers to. So at the heart of this optical tracking is a CPU, a computer, which creates one unified space, and then every instrument, the patient, and every device that moves into this space refers into the same three-dimensional coordinates. And this has to happen at the very beginning of the surgery. So before you start using a navigation system on the patient, you have to register all the tools towards this three-dimensional system that the CPU has created. And this registration process requires specific devices, attention and focus, and aim to make this seamless and without any errors at all. You see, if you have an error in your registration, then it might follow for the whole procedure, and sometimes might be difficult to spot unless you really know where to look at. And if you are attacking zombies, then the registration error might mean that your gun is not aiming very precisely. But if your registration is not correct in implant dentistry, it might also mean that your implant might not be placed so accurately. So we do have checks and balances throughout the whole workflow to make sure that every step is completed properly, and then in the end, the accuracy we get is what we expected to get. Now, when we compare these two different approaches, the static and the dynamic, it is very different technologies, very different principles. They both have been documented to achieve high levels of accuracy, but from very different standpoints. One thing that is very important from our perspective as a university program and as educators is how important is the learning value of these technologies. Now, if you look at the surgical guide, it is a procedure that is easy to learn, easy to achieve, let's say, the maximum accuracy within a few cases, but has a very little learning value for someone. If you place implants with a surgical guide, you will not become a better surgeon when you try to do this freehand. On the other side, the navigation devices, they have a very different approach, being freehand surgeries in a sense. However, cognitively, they have a different load. It might be more difficult to learn, more time-consuming to master, but it has also a higher learning value. Once you train with navigation devices, you can also become better in freehand, non-aided surgeries as well. You might have heard the expression learning curve when we want to describe how difficult it is to master a skill. It is actually not just an expression, it's a real equation behind it, which was conceived to describe the difficulty of mastering specific competencies. So on a graph, we have on the vertical axis the percentage of mastery, with 0% being the novice and 100% being the expert or the proficient user. And then on the horizontal graph, the part of the graph, we have the time we need to spend on task with training for the specific skill. So you see the learning curve as it is depicted in this graph for the static computer-assisted implant surgery, the surgical guides, is what we describe as diminishing returns. The skills rise quickly, so with relatively little time you can reach the maximum capacity or the maximum accuracy you can get with these surgical guides. On the other hand, when we're looking at navigation, the learning curve is different, is the opposite, is what we would call increasing returns. The skills rise very slow in the beginning and you have to spend time on task, but then after a certain point they rise much faster, and then you can reach really high level of expertise thereafter, which means that it takes more time. You need to invest more time, but eventually your mastery grows, and once you get confident with this technology, you can achieve really very high level of accuracy. Now, why would this be? Why dynamic navigation teaching and learning is so particular? I think it's many reasons for that. First of all, of course, you need a lot of componentry that you need to install, that you need to place in different positions, and certain procedures that you need to conduct before the surgery, and also certain things you need to be aware during the surgery. Then there is an ergonomics challenge. And very often, in order to make sure that all the ergonomics make sense, that the trackers are placed in the right position, that the vision of the cameras is not blocked by any movement or by hands or by other devices, some of our residents, they have to rehearse their early dynamic navigation surgeries to decide where exactly to place each tracker for optimal connectivity with the cameras. But there is also another parameter, and this parameter is the cognitive load. It is a much more complex cognitive task to operate with navigation. Why is that? Because we are trained in a certain way. Our dentists have been trained to focus our entire attention at the tip of our fingers. Imagine when you're working with surgery in the oral cavity, your entire attention is focused in a couple of centimeters next to your instruments, and you're looking with all your attention span power into this very space where your fingers are moving. Now, when you're operating with navigation, the paradigm is very different. You have your fingers moving in one physical location, in one physical space, and then you have your eyes looking in another physical location in a screen. And the two-dimensional screen gives you the information that your brain then can unify with your fingers, and you end up working in a virtual place where your fingers and your eyes are combined. And this is not a natural working position for us dentists. It takes training, it takes some growth. Of course, we can all grow into this, but it's not how we came out of the dental school. And that, I think, is one of the cognitive challenges that one has to overcome when getting trained with these technologies. But you know, there are people who are quite natural in this skill, in the skill of keeping your fingers physically in one level and your eyes on another, and then your brain reconciling everything in a virtual environment. Can you think what kind of people is that? Well, I'll give you a clue straight from science. It was about 20 years ago when publications started to emerge showing that people with a history of computer gaming had actually a head start, an advantage, when they were training with endoscopic surgery. And I think today this is beyond any doubt. After several clinical trials and even meta-analyzed, we know that people with history of gaming have an advantage in kind of surgical training, especially with digital technologies. So you see, surgery is changing. And it's not only that we introduce new tools, it's actually that the tools shape surgery to look even more like a computer game. And surgeons today have to train in very different ways, not in order to only get manual skills with their fingers, but also to be able to control devices through screens with very fine manipulations, pretty much reminiscent of a computer game. And I think we have to prepare for this era, because this is coming increasingly in oral surgery as well, and the benefits of it will be even more pronounced in the future. So we do use a lot of navigation surgery for training purposes, because we have also found that people who train with real-time navigation not only learn to use this technology, but they also benefit in their free surgical skills. So when they try to conduct operations without aids, without navigation, they have improved their surgical competencies thanks to the training with the navigation. So if I was to sum up a little bit our policies and our strategies, in that we want to start early with clinical training. We want to start early also with navigation surgery. Our strategy is to first try conventional implant surgery on the sim lab, and right after continue with navigation surgery on the sim lab. Then when moving to the clinic, start straight away with conventional implant surgery. After a few cases of conventional surgery, then move to navigation as early as possible again. And only when the skills of the respective procedure are mastered, then we can move on also to have some static surgery with surgical guides. Because surgical guides will add efficiency, they will not, however, add any learning potential. Placing many implants through a surgical guide will not necessarily make you a better surgeon, will deprive you of your visual and your spatial and let's say perceptual abilities. Let's now move into the case that we would like to discuss today, which falls into the category of immediacy, and it's what we would call today immediacy of type 1A. This classification comes from Gallucci et al., was published quite a few years ago in an ITI consensus workshop, and it is the first one that actually merges the surgical with the restorative aspects of immediacy. You see, in the past, immediate implant was considered any implant that is placed in a fresh extraction socket, and that was described as type 1. But in reality, it's not only important why you place it and where you place it, it's even more important how you place it and if and how you restore it. So today, immediacy will have three different aspects: 1A with immediate placement and immediate restoration, and then 1B, 1C depending when the restoration comes. And based on all these parameters, you might have completely different clinical indications, but also treatment outcomes. Immediacy 1A is one of the most minimal invasive approaches. It is done flapless in the aesthetic zone, and it's not only giving immediate aesthetics, but it also allows us with a minimal intervention, without cutting and without suturing, to preserve as much as possible the architecture of the tissue close to the original, what it was when the tooth was there. So our patient today will fall in this category. Is a young lady with a beautiful smile and also with a profession that requires her to smile very frequently and very sensitive on the aesthetics. Unfortunately, the lateral incisor 2-2 is fractured. There was a crack with a crack line going deep palatally under the soft tissue and marginally under the bone, which is beyond any possibility for maintenance and restoration. So in this case, we are looking into the case and we decide that that will be an optimal case for a minimal invasive immediacy, for immediate with an immediate prosthesis. The treatment plan takes in consideration the exact anatomy of the patient and the anatomic conditions. It starts with the ideal crown, which we have. We don't want to redesign it. We really have the optimal crown. We just need to replicate it. Then, through the supracrestal complex, we can identify the optimal position of the implant, ensure that we have good conditions for primary stability, as we do have good quality and quantity of bone here apically of the root. And then we go ahead and follow the cases and the steps that we saw before to plan the case. Now, once we have the treatment plan conducted, in this case, we would go for a surgical guide and a prefabricated crown, but we will follow the navigation, so we will not follow the static approach here. So we don't need to print a guide, we just need to prepare the prefabricated crown. And here comes probably the first glitch. You see, in an ideal world, we would be able to place the implant and have the prefabricated crown ready to put on top. But the implant planning software, the navigation software, and the implant system we're using do not talk completely to each other. And what they don't exchange is the orientation of the internal connection. Which means that I could place the implant in the exact position with the navigation, but I would not be able to know which is the orientation of the internal connection. So if we try to place the crown as a prefabricated, pre-cemented on the abutment, we might not be able to know if the crown will be fully aligned aesthetically as it should be. So to bypass this glitch, we have two options. One is to print a surgical guide for only the very last step with knots to align the internal orientation from one software to the other. And the other option is to just make a non-locking crown on the abutment. So the abutment will be placed on the implant and the crown can be placed on top and then picked in the optimal position and cement it outside the mouth. And in this case, we opt for the pickup approach.
In here, I would like to add on more with the prosthetic jig or the pickup jig for the temporary crown. So you can see here on the right side that we have the printed jig and also the printed shell crown. So in this, we have to make sure that inside of this shell crown is hollow. We have to create a space and make sure that when you place the jig and the temporary crown in the patient mouth that already have an implant connected to the temporary abutment, this thing will not bind or jam with the temporary abutment. It has to have a space. So after you make sure that everything is seated with the space, you can load this temporary crown to the temporary abutment. Take it outside the patient mouth, add the composite and make sure everything is polished and good, get the good immersion profile.
Now let's move on to see what happened in the surgery. You see, in this case, we added one step to the digital workflow and our treatment plan, and that was partial extraction therapy. Partial extraction therapy is a concept of preserving a very thin slice of the root buccal surface, approximately in the buccal wall of the socket, in order to preserve the conditions of the tissue there as intact as possible and prevent any future resorption. Now, this is not a digital concept because we did not plan for the partial extraction therapy into a digital treatment plan. So here I'm jumping out of the digital workflow and I'm doing this in the conventional analog way. The protocol that we will follow requires certain instruments and starts with decoronation. So I will have to decoronate the lateral incisor in order to be able to detach the palatal from the buccal segment and then modify the segment appropriately. We use a certain sequence of instruments and special devices for that. And here I'm starting with a diamond burr, just cutting flat the crown of the lateral. Here you can see the fragmented segment of the crown. I'm removing this part and the crack line goes well under the palatal side of the bone. Now, we initiate this partial extraction therapy with a special lance drill, which is meant to reach the very tip of the apex of the root. So it should go through the entire root canal and end exactly at the apical segment of the tooth. And this is pre-measured and a stop is placed. Now, unfortunately, here we have a little bit of a variation because the root tip is angled towards the distal, and as I realized later, the lance tip did not really go through all the length. There was a small tip still below this lance drill. Now we're using a Lindemann drill. This is a drill that cuts sideways, and we move it in order to separate the buccal and the palatal segments of the root. And I'm finishing this with a piezoelectric tip. Again, this is not digital, so I do not have any guidance other than my own tactile perception and understanding. And I think it's inevitable also that some parts of the socket are getting damaged while preparing this segmentation of the two parts. Here I have segmented buccal and palatal parts of the root, and I'm going to try to detach the palatal piece with the periotome. Again, fully analog and fully relying on my own experience. This proves to be more difficult. It's a very small segment now, the palatal part of the root, and very well attached with little grip. So I'm going to take a piezoelectric tip again in order to detach it. Finally, this piece comes out, but not including the very small apical part. So there is a very small piece of the apex still into the socket. I will try to visualize it better by now removing some parts of the buccal segment. So these round diamond burrs are just trimming away the part of the buccal root that I want to take out, hopefully resulting into a very thin slice which will be only placed at the level of the socket wall. This will allow me also a better visual contact with the root tip and hopefully a better ability to scoop it out and then place the implant. So this is now the final outcome. We have leveled the root tip quite significantly. We still need to trim it more down to the level of the socket. And here I'm trying now to use the piezoelectric tip to extract the last root tip that is still stuck at the bottom of the socket. And here I'm probably going a little bit beyond what the socket walls allow. So that might be a critical point, because now the socket walls might be damaged, and then the ability to get primary stability as it was on the digital treatment plan might not be the same when we will try to place the implant here. But here comes the root tip. So finally, mission accomplished. Now we can go ahead, finalize the shape of the shield, suppress it completely down to the level of the socket wall. This instrument is meant to be grinding down from the top to bottom, but it also damages the soft tissue. So I'm reverting back to the diamond round burrs with a special shield. Still, the thickness you want of this part is very small. You want essentially a couple of millimeters, maybe less than that, just to maintain the periodontal ligament in place. And now the time comes finally for the implant placement. And the implant placement will happen with a dynamic navigation. We register into our system the first drill. You can see there is a clip in the mouth of the patient which is holding the tracker. Now the cameras can look at the handpiece tracker and the tracker of the patient and give me real-time feedback in the screen, which you will be able to see as soon as my assistant moves out of the way. Now here you see this bullseye, which is surrounded by the yellow line. Once I align the angle and the position, then all I have to do is start preparing the osteotomy, and then you will see the yellow line gradually becoming green and finally red. And when you reach the red, it means you have just reached the end of the osteotomy. You have reached the depth of the preparation that you have planned for. So, not much different than a video game at this point. And that was the first drill. Now we're going to the second drill. Again, register the second drill in the system and place it, align the angle, and finally move on to the preparation depth. There was a temporary loss of connection through probably some obstruction to the cameras, but now we have reached the final depth of the osteotomy, and that was it. The implant preparation and osteotomy, as you see, was just a fraction of the entire procedure that we had to commit for preparing the partial extraction therapy. But now the implant placement can happen exactly in the same way with the navigation. We just place, align the angle, and continue until the final depth is reached, and that was it. The immediate implant placement through a video game lens has become much more predictable and much more efficient. With the implant in place, now we can move on to test whether our prosthesis will fit and then finalize with the augmentation stages.
Now that the implant is successfully seated in the socket, it's time for delivering the provisional restoration. Looking at our plan in the software here, you can see that this isn't just a temporary tooth. We are executing a digital design that mimics the patient's original tooth contour to the ideal aesthetic. So this here is the critical clinical payoff of this tooth number 22. The major advantage is that in this case, we are starting with the patient's original tooth contour. So by preserving that natural blueprint to our digital design, we eliminate the guesswork. We didn't have to reinvent the emergent profile. We just simply replicate the nature the patient has. So as you can see, this approach allows us to support the soft tissue and papilla exactly where the original was. By overlaying the CBCT data with our pre-extraction STL file, now we have the design of the exact emergent profile needed to support the soft tissue. To execute this in precision, we used, at that time, we used ExoCAD to design the exact contour of the restoration. So you can see in 360 degree that we have the correct emergent profile, like the critical contour and subcritical contour that we just mentioned. On the left, we are using the software to overlay the original tooth anatomy to make sure that emergent profile is ideal. So now, the upper right, you have the 3D design, and then we print the shell as we design. And then we will do the pickup in the patient mouth. So the implant is in. Now, how do we make sure that tooth sits exactly where we plan in the screen? We use this restorative jig. So on the left, you can see the 3D model that we designed this jig on top of the design shell crown. So we print this jig out and use it in the mouth. So on the right, the jig is in action. It seats firmly over the adjacent teeth to stabilize and align the crown in its exact 3D position. So this is the key to a predictable chest-side pickup. It ensures that the emergent profile that we engineer in the software is perfectly replicated in the mouth with no guesswork or shifting during the loading process. Here we see that the prosthesis jig is seated firmly over the adjacent teeth because we hollow out the internal aspect of that printed shell. It seats perfectly over the abutment without jamming, leaving just enough space for our loading resin to capture the precise position. So once the resin is set, we remove it extraorally to finish. At the time, we decided to do the scanning to get the implant position just as a backup, just in case that the patient came back and break his temporary or her temporary crown and need a new one, we can make it right away with the data from this scanning. So we decided to put the scan body in. But as we all know, clinical reality doesn't always follow the digital plan. While we were removing the scan body to capture the backup position, the implant actually moved because it lacked the primary stability we expected. To save the case, Dr. DeCos has to seat the implant further apically to finally engage enough bone for stability. But this created a major problems because our prefabricated provisional was now completely useless because the 3D position has shifted. We had to adapt instantly. We switched our strategy to use the customized healing abutment to manage a deeper platform. This customized healing abutment was made by just cutting the temporary crown we had before to the gingival level which you will see in the next video.
So after all this now has been finalized, it's the time to complete with the augmentations. We are going to augment in two different ways. We will use xenograft to augment the bone part of the socket, what is meant to become eventually embedded into new bone. And we're going also to augment the soft tissue part, which is going to give us, maintain the space for the new peri-implant mucosa to grow in. So we start with a xenograft with collagen, which is filling the socket space between the implant and the walls of the socket. And this is going to be lightly packed all the way in and all the way up to the bone margin of the socket. I do not want to pack xenograft higher than that. I do not want xenograft to be mixed with the area where it's meant to be soft tissue. This process is simple, relatively straightforward. Fill in the space, make sure you don't have particles of the xenograft scattered in areas you don't want them to be. Well packed, lightly packed, only from the level of the implant shoulder and within the bone walls of the socket. Then once this xenograft is packed all around the implant, we test the customized healing abutment and we design the final touch. Here, this customized healing abutment is going to fulfill some very essential purpose, and it's not going to give any aesthetic support, but it is going to support the tissues and support the architecture of the soft tissue as it was originally with the tooth. Once this is final, we use some collagen sponge into the area where the soft tissue is going to grow. This collagen sponge is going to be supporting the blood clot as long as it takes until the blood clot is being resorbed, being turned into granulation tissue, and eventually new peri-implant mucosa grows into this space. And of course, this is supported by the shape of the customized healing abutment, which imitates the ideal emergence profile and stabilizes the tissues on top, protecting the underlying augmented areas. Now we close the access hole with composite, and from this point onwards the implant is safely into the socket. The augmented area will start gradually to maturate with new bone migrating in between the xenograft particles, while the soft tissue component will gradually also change and transform into the space of new peri-implant mucosa. Of course, this is not solving right now the aesthetic problem, the immediate aesthetic problem of the patient, which the prosthodontist will have to direct right away.
So now it becomes prosthetic problems or aesthetic problems. We had to adapt instantly. So we switched our strategy to use this customized healing abutment to manage the soft tissue in this new implant position. And then for the crown part, we went back to the lab and print another temporary crown and shaped it to a veneer and use it as a resin bond temporary veneer on the adjacent teeth. So we bond this printed veneer to adjacent teeth. So we learned that this is a powerful reminder that the software gives us a map, but biology always dictates the journey that we have to do. So this is right after surgery. This is our final result at day 0. despite the surgical complication, we were still be able to achieve our biological and aesthetic goals. Underneath this surface, that is a customized healing abutment that doing their job, shaping the soft tissue and supporting the soft tissue architecture, and also keep the grafting material perfectly underneath and undisturbed. On the facial aspect, the bonded veneer that we gave her, it satisfied the patient's immediate aesthetic demands. By separating the look from the load, we have created a soft environment for the implant under to integrate and also give the patient seamless result when she smiles in the day one. And of course, we have to check that this restoration has no contact in centric and eccentric. This is 1 week follow-up. Fast forward to the 1 month follow-up. The patient was very pleased with her aesthetic. Look at the health and maturity of the soft tissue. Gingival margin is remarkably stable. We have successfully preserved the natural scallop architecture of the soft tissue. By using that customized healing abutment, we essentially kept the soft tissue in a good place. And the bonded veneer is still performing its job, keeping the patient aesthetic high. It is exactly the stability we look for before moving forward to the final restoration phase. So, because what do you think? Does the plan go well? Do you have anything to comment about our treatment?
Indeed, this was a learning case. I think this is a case where we start to explore the margins of the digital treatment plan. You see, the digital plan accounted for the fact that we place an implant in the extraction socket. It didn't include, however, the partial extraction therapy. That was an analog intermission into our workflow, which did not go as planned, because probably during my attempts to extract the last bits and pieces of the root, I over-prepared the extraction socket, which impacted the primary stability. Now, with digital technology and the navigation being essentially a freehand surgery, I still had the chance probably to modify the position of the implant to go a little bit deeper and get a better primary stability, but that would have changed the whole prosthetic design. So in this critical moment, I probably underestimated the stability that I had. I didn't have as much as I thought I had. I didn't double check, and I kept the position there, which resulted into this spinning that was dealt with by an experienced prosthodontist. So what about your experience? How did you see the whole workflow going?
So for me, I think things can happen even you think that you have advanced digital tools or the support that you have. For example, in this case, we have to change our temporary crown to customized healing abutment, and we have to do the veneers and bond to adjacent teeth. So that's what happened in this case. It doesn't mean that technology can replace your expertise. Sometimes you have to interfere, you have to get in and then use your experience and change or do the treatment in an analog way.
Now, reflecting back, I think in the future, as our tools improve, we will get more and more possibilities, including planning the partial extraction therapy fully into the digital treatment plan, which will help us then more precisely execute the workflow. So don't forget to follow us to get the latest in implant dentistry and aesthetic restorative. And I think we can now jump directly to discussion. I see a lot of our friends have already posed questions.